Hello. This session explores the support a student with a physical disability might require. My name's Michelle Cowan and I'm a lecturer within Health Sciences, an academic lead for disability and dyslexia. There are two aims for this session. Firstly, to explore the different types of physical disability that students might present with, but more importantly, to consider what support these students might require. In other words, reasonable adjustments. In an earlier session that examined your legal responsibilities, we looked at the definition of a disability as stated by the Equality Act of 2010. If you remember, this defined a disability as any condition which has a significant adverse and long-term effect on the person's ability to carry out everyday tasks. From this, you might like to consider what types of condition could be classed as a physical disability. For the purposes of this session, I'd like to focus on mobility difficulties, visual impairments, hearing impairments, unseen disabilities such as diabetes or epilepsy, physical impairments, and finally latex type 1 allergies. From this you can see that the range is enormous, and for each of these disabilities there will be a huge personal variation. Each case must be considered on an individual basis to explore what adjustments the individual will require. In my experience, the vast majority of these will be considered reasonable and will be implemented relatively easily. There may very occasionally, however, be a proposed adjustment which requires much more careful consideration. In these cases, we hold a case conference with the relevant Central University Department or Occupational Health and explore the adjustment further before discussing it with our practice partners. Remember that it's a legal requirement to provide reasonable adjustments, and it would only be if you could really justify in court that a requested adjustment was unreasonable that it could be refused. Even prolonged and recurring health problems are likely to be able to be supported. However, there may be professional regulations which influence this. For example, the Nursing and Midwifery Council currently require students on a full-time course to complete within 5 years of entry. This may be a problem if a student is likely to require lengthy periods of sick leave during their training, and it may be wise for the student to defer entry until their condition improves or stabilises. There are also fundamental differences between the two regulatory bodies. The Health Professions Council allows students to register with a restricted scope of practice. This acknowledges that for a reason such as a disability, there may be aspects of the role which the student isn't able to perform. The Nursing and Midwifery Council, however, currently requires students to demonstrate proficiency in all of the competencies, and an inability to do so will mean that the individual cannot enter the register. Before we go on to look at individual conditions, it may be useful to consider how society considers disability and how a move to a social model of disability might improve inclusivity. Historically, we've been used to a medical model of disability, which has categorised things as disorders or deficits or difficulties that the individual needs to overcome. Recently, however, there has been a move towards something called the social model, which suggests that it's society's attitude that's the problem, and it's created by a society that fails to adapt to the need of the individual. The majority of the health problems that a student may present with will not affect the student's ability to meet the programme requirements and are no barrier to admission. The challenge for us is to see how we can support the students to succeed. The following video clip shares one student's story. The student concerned has had a disability since birth and was quite surprised by the reactions that they encountered when they commenced a placement.
I'm a newly qualified staff nurse. I have mobility problems. When my son was born, I wanted to do something different. I'd already done an access course and I wanted to do nursing. So I was born with my disability, and so it doesn't really occur to me that other people would see it as a problem. I mean, I just really adapt around it. One of the questions on the application form said, do you have a disability that affects your day-to-day life? And mine doesn't, so I said no. I think that was my first mistake, because although I live with it and I'm used to it, and the people around me are used to it, it's the first thing that anyone new really sees. The first time this really hit me was on my first placement. I hadn't really done anything like this before, and it was quite scary anyway. I spoke to my mentor within the first few days, and one of the things they wanted me to do was pushing around a lot of theatre trolleys, which were quite heavy, and I was quite slow when doing it. My mentor thought that I was too slow, and so she stopped me from doing it, which was such a shock. She said that she was surprised that someone with my disability had got a place. I think that was the first time that it really hit me that it was obvious to other people. Because when you grow up with it, you forget that there are things that you can't do. I suddenly felt like a person who had a disability and that it was going to be a problem. I came very close to actually throwing in the towel. But the university were great. I mean, they were really, really supportive. When I did things like basic life control, they put the mannequin on a bed rather than on the floor, which really, really helped. My message to mentors would be, don't look at the disability, look at the person. Don't look at what people can't do, but what they can. I mean, everyone struggles with different things and everyone has different difficulties. And so look at what they can do and the contribution they can make. One staff nurse said to me that she had enormous admiration for me. But I don't want her admiration. I want her to think that I'm doing a good job, and not just because I'm disabled, but because I'm doing a good job. Don't look at the disability, look at the person.
The range of mobility problems which a student may present with are considerable, and it must be remembered that every student should be considered as an individual and in the context of the professional programme for which they are applying. For example, it may be easier to accommodate a required adjustment for a student entering a course regulated by the Health Professions Council, which allows students to register with a restricted scope of practice, than students on a nursing or midwifery course. Difficulties with mobility may be as a result of genetic influences, illness or an injury, and may include problems with an unsteady gait, a limp. You may encounter students who've had an amputation and use a prosthetic limb. Very occasionally, you'll encounter a student who uses a wheelchair, but much more common are students who are in pain and have pain on movement or an inability to stand for long periods. Depending on the nature of the student's mobility problem, the following adjustments could be considered and a risk assessment completed if necessary. In terms of risk assessments, you may have a local policy as to when these are required. This is often influenced by health and safety legislation, and students with mobility problems are likely to require a personal evacuation plan, or PEP. This considers how they would be evacuated in an emergency such as a fire from campus-based activities, halls of residence and practice placements. Risk assessments will also identify specific hazards in an environment and seek to remove these or look at how the risk associated with them may be minimised. In terms of adjustment for students with mobility problems, alternative shift patterns, including shorter hours, are often quite helpful. Considerations of travel requirements, making sure the student is placed somewhere geographically close to where they live, where available, particularly if they're reliant on public transport. We may need to recognise that they need to sit down for certain activities or rest more often than other students. Students may need to use mobility aids such as a stick, crutches, or use a wheelchair. And in situations like this, it's particularly important that the personal evacuation plan is carried out. Sometimes selection of appropriate placements may be necessary. Community placements are particularly challenging, and it's very difficult to risk assess a person's home. This calls for those responsible for organising placements to be creative and give the students as varied an experience as possible within their personal constraints. There are between 1.5 and 2 million visually impaired people in the United Kingdom. The term visual impairment refers to people with irretrievable sight loss, which covers a wide spectrum of different impairments, including problems with depth or field of vision. Only about 1 in 5 registered blind people can be described as seeing nothing at all. Others will have some perception of shape and light. Visual impairments may be static, vary according to outside factors such as level of lighting, or be progressive. In other words, they're likely to deteriorate further. In addition to the level of impairment, how it will impact on the individual is influenced by the age they were when they became visually impaired, what training and support they've received, often through organisations such as the Royal National Institute for the Blind, RNIB. Presence or absence of other conditions such as diabetes may also have an impact on the level of sight. And finally, strategies that the individual has developed.
I'm a second-year nursing student with a visual impairment. When I went in, I asked if they wanted to do a risk assessment, and she said, no, don't worry about it. And she went on to describe other situations where they would do a risk assessment, like for a latex allergy or something like that. She then went on to ask me to what degree does my disability affect me. I think she was really pleased to know that I know my disability best and I know my own limits. The senior sister asked me, so what help do you need? I said none really, I might just need some visual aids. She said that was fine, she was really cool about it. She came to visit me today. She doesn't check up on me, she just needed to let me know that one of my shifts had changed. My mentor's the same, she's really great, she's always asking me if I need any help with anything. And she doesn't not let me do anything as well, which is brilliant. She just says, oh, next time you're doing it, which makes me feel really good. I never thought I'd be back on the ward again, let alone doing anything within nursing. So it just shows that I can still be a nurse.
Students with a visual impairment are likely to benefit by provision of specialist equipment. This may include items such as a video magnifier or an optical scanner, which they can use to enlarge things, both in theory and whilst out in practice. Provision of a digital voice recorder will reduce the amount of notes they have to write down. They're also able to use this to listen to things they've pre-recorded. Assistive technology programs on a computer may include voice recognition software or programs that read text aloud. Students with visual impairments will also benefit from having written materials made available in larger text versions. Sometimes access to a support worker, for example a reader or someone who can take notes for them in lectures, is beneficial and is a recommendation. Like students with mobility problems, a risk assessment of their working environment will help to identify specific hazards. Another thing to consider would be flexibility over working hours for students with visual impairments. This may allow them to travel within hours of daylight. Finally, good practice would be to allow students time off to attend assessment, treatment or rehabilitation, but professional regulations may require that this time is made up. The next area to consider relates to students with a hearing impairment. Level of deafness, mild, moderate, severe or profound, is defined according to the quietest sound measured in decibels that can be heard by an individual. So for mild deafness, the quietest sound the individual would be able to hear is between 25 and 39 decibels. For moderate, between 40 and 69. Profoundly deaf individuals will only be able to hear sounds over 95 decibels. However, even people with mild deafness will find it difficult to follow speech in a noisy environment, such as a clinical area. When an individual is classed as severely deaf, they will probably rely on lip reading, even if they wear hearing aids. Whereas for those that are profoundly deaf, this is likely to be their main method of communication. There are lots of things we can do to help students with hearing impairments. To start with, if you can speak clearly and ensure that you're facing the student, it facilitates lip reading. Provision of equipment, such as an enhanced stethoscope or a telephone, is also important. But remember that these need to be compatible with the student's individual hearing aid, and expert advice is therefore required. Again, assistive technology programs, such as voice recognition software, or programs that read text to the listener through earphones, will help students with hearing impairments. Access to a support worker, for example a note taker, and risk assessment of their working environment, along with the ability to attend specialist appointments in audiology for ongoing assessment and treatment, are also important to the individual. Although some disabilities are immediately visible, there are others that are unseen, including epilepsy and diabetes. The individuals affected by these conditions will probably not view them as a disability and probably won't have told you. But both conditions are recognised as a disability under the Equality Act. If a student feels that an adjustment is required, it will be a legal requirement to do so. Potential adjustments include regular meal breaks and possibly consideration of shift patterns. Students with diabetes and epilepsy may find that their conditions become less stable if they're required to undertake night duty, and as a result, programme managers may decide that this is not a course requirement for them. In contrast to these students with hidden disabilities, the next group we have to consider are those with physical disabilities, which may be immediately obvious and include things like missing limbs or digits as a result of genetic influences or following amputation. In all of these cases, the individual has probably perfected their way of doing things, and one of the greatest obstacles they need to overcome is other people's attitudes. Other adjustments may include provision of specialist equipment to aid manual dexterity, or purchase of gloves designed to fit the individual concerned. The following clip talks about one student's personal battle and how they succeeded in overcoming the obstacles they encountered.
When I filled in the application form, I mentioned that I'd had a couple of operations on my hands, which meant I had missing fingers. I said that this hadn't affected me in daily life, apart from that I'd had extra time on my A-levels. When I started, I went into practice and met a couple of negative mentors. They wouldn't let me do anything because they thought I wouldn't be able to do them. They kept doing things themselves without letting me have a go, like aseptic techniques. I could understand if this was an emergency, but these were routine procedures, and I just ended up doing things like observations and washes. I explained that I just wanted to have a go, that I probably could do it, just let me try. Then, in my second year, I met a really positive mentor. She said to the other students to just rope me in, let me have a go. It was nice because then at least when other people are so negative, it makes you wonder about yourself sometimes. As I've learnt doing things, I found ways that have suited me. Like with a syringe, I have to use both hands, but it's just finding a way that suits me. I qualified last year and I'm now working in intensive care. I think that shows that I can do it.
The last area to look at are sensitivities or allergies to latex. Latex is formally known as natural rubber latex or NRL. Type 1 latex allergy is the most severe and may result in an anaphylactic reaction. A lot of students will develop sensitivities, but these can progress and become a full type 1 allergy without warning, so staff need to be aware of this potential and be able to respond accordingly. The preferred approach is to eliminate the use of latex wherever possible. However, latex is a naturally occurring substance and occurs in grass and banana skins. The Health and Safety at Work Act places a duty on individuals to take reasonable care of their own health and safety and to cooperate with their employer, in this case deemed to be the practice provider. Unlike other types of disability, where it's a student's choice as to whether they disclose or not, health and safety legislation requires all students with a latex allergy or sensitivity to disclose this to practice. So in terms of preparing for a student who has a latex allergy, the education provider will notify you in advance that a student has a latex allergy or sensitivity. The environment must then be risk assessed and, where possible, latex products removed. In areas where it's not possible to completely eliminate latex, the area should be risk assessed and consideration should be given as to whether an alternative placement is required. Certain environments, though, including patients' own homes, cannot always be fully risk assessed, and both the student and the staff they're working with need to be fully aware of what action to take should a reaction occur. Students need to make sure they have their medication, which is usually an EpiPen, with them at all times, and take responsibility for self-administration. However, if they're unable to self-administer or do not respond to their medication, the local emergency anaphylactic protocol should be followed. So in conclusion, education providers and practice partners have a legal responsibility to ensure that all students are not disadvantaged, irrespective of any disability. For many students, no adjustments will be required or they'll be minimal. However, for some students with a physical disability, more specialist support may be required. This may be in the form of accommodations made to their working environment, provision of specialist equipment, but most importantly, through a culture that embraces inclusivity. This session has hopefully raised your awareness of the wide range of physical disabilities which healthcare students may present with, and helped you to identify how you can support them to achieve their potential. For me, one of the most powerful things was listening to the students' stories and hearing how even little things can make a difference.